Good morning. First of all, I would like to thank the organizers, Professors Fakon, Nagler, and Mohti for inviting me and including me among the faculty of very prestigious myeloma doctors and experts. And for those of us who have been treating myeloma patients for a long time before the era of proteasome inhibitors and IMiDs, we knew how difficult life was earlier. And with these new drugs, we are now more happy. And during the last 15 years, it's been a major advance in the recognition of the mechanisms lying underneath the development of myeloma. And certainly there are issues related with intrinsic factors due to the plasma cells, and also extrinsic factors, but nothing to forget is the baseline underlying susceptibility to develop myeloma. So once we have the myeloma developed, then we are restricted by the healthcare system and the resources that limit us with the type of treatment that we have to give. So we are not lucky at this point to be able to give treatment based on precision medicine, and we are treating most patients in the same fashion, which eventually leads up with progression and relapse, which we have to face and treat the patients. And in that case, then it comes to the question raises how to treat them, how to combine treatments. And today my job is to bridge from transplant to the immunotherapy, I guess. So that's it's going to be a replication of what has been discussed yesterday. But I am going to try to combine the biology in a kind of a translational manner to interpret the data of phase 3 trials of the recent couple of years. So proteasome inhibitors are certainly among the most important ones, and we know that the plasma cells, due to high protein production, they are more sensitive to proteasome blockage. And the reason and the outcome is the consequences, the second steps to follow to apoptosis with the inhibition of proteasome. And Bortemomib was the first to be involved in this step. And I wanted to emphasize the importance of proteasome inhibition because with this mechanism and leading to apoptosis, we are involving mechanisms which also have the potential to interfere with the IMiD activity. So that's why I included this slide. And during the progression of myeloma cells from the classical myeloma to more immature forms, there is a change, and acquired mutations end up with interfering with the NF-kappa-B amplification and the signals. And so there might also be the eventual outcome that NF-kappa-B reduction can also occur, which means that in the steps to follow in the treatment of myeloma patients, we need additional drugs or newer proteasome inhibitors which are more potent to address these problems. So we have to treat patients before these new mutations acquired, or agents which address the cells which have acquired these mutations. And we were very lucky that the newer proteasome inhibitors entered the field, and so far some of these drugs some of them have reversible and some have irreversible activity, but not all of them are targeting NF-kappa-B. That is something to be remembered. But there are such as Bortezomib versus Exclusion, their targets are not exactly the similar ones. And certainly carfilzomib, which is an epoxy ketone, differs from bortezomib. So that's why they might have different activity and efficacy. And these drugs have become approved during the last 3 years. And so this gives us the advantage to compare the phase 3 study results. And it's, of course, not relevant to compare one study versus the other way, but there are sometimes tools to be able to do some comparison. And with the proteasome inhibitor-based or Bortezomib-based studies, I would like to comment on 3 studies, although my job is not to allude to monoclonal antibody combination. But these are the 3 studies which have used Bortezomib dexamethasone as the comparator arm. And here you are able to see that the median line of therapy before the inclusion into the study is not the same, so which makes it difficult to compare the outcome. And also the study population, which includes, for instance, high-risk cytogenetics, which is the lower part of the table, is not similar as well. And yesterday, however, he mentioned that the high-risk definition is no longer maybe the same as it should be, and we have to revise it. And in these studies, usually chromosome 1, for instance, is not involved, and so the description of high risk is not the same, and for instance, the 7TP deletion cutoff is not the same as well. But still, patient populations are different, and if we want to compare the response rates between across these studies, the CR rates and the hazard ratios here favors the panobinostat arm, which is the Bortezomib comparison. The hazard ratio is 0.6, and but overall the CR rates are very low. These are not very equivalent to the newer results that we have obtained with the monoclonal antibody combinations, and the median time for treatment and also the treatment cycles are not similar as well. Here you can see that in the ENDEAVOR study, both arms received treatment until progression, whereas in the Panorama study it was 12 versus 8 cycles, and in the CASTOR study the control arm received only 8 cycles, whereas in the other arm, patients continued to receive daratumumab until progression. So these make a major difference. And regarding the safety issues, we have a signal here that with the introduction of carfilzomib comparing to bortezomib, the adverse events are much less, serious adverse events are less, and discontinuation rate is not very high either, and that is very low. So we can conclude from here that apart from panobinostat study, the newer drugs are maybe more tolerable. And furthermore, regarding the cytogenetic risk profile, which was the primary aim to introduce these newer drugs to increase the efficacy and also to target high-risk populations, here we don't see a signal in favor of carfilzomib in high-risk patients. And this could be two various reasons, and one of them is maybe you realize that these patients are more advanced compared to the other studies, and which I'm going to show later in the IMiD part of the presentation. So here we can say that there is no major impact on high-risk cytogenetics with carfilzomib versus bortezomib. And but this is not the conclusion, although the order is not ready yet, but I would like to show you with the KRD and tourmaline, which I'm going to show later, the signal for high-risk patients is more prominent here. So with the IMiD plus a proteasome inhibitor combination, it seems that we are more approaching to overcome high risk, and this is the best which can be achieved with the daratumumab bortezomib combination, and it looks like this combination is overcoming the high-risk features of the relapsed myeloma patients. So conclusions from the PI-based studies, we can say that the studies are not comparable, the treatment durations are not the same, but they are less toxic, and and also double refractory patients are not included here, so there's an unmet need in this part, but there's a signal that there might be a way to overcome high risk. And so far, we don't have any data regarding the individual patient heterogeneity. And to continue with the mechanisms to be addressed in the myeloma patients, there are other issues than the central NF-kappa B. So interaction with the microenvironment and other signals that lead to proliferation of cells. So there is a need for additional drug class, and certainly IMiDs are among those. And with the immunomodulating agents, we know that we have the last 10 years have led to the description of the mechanism of action, and cereblon is the target. But what happens is the transcription factors that are related and ending up with survival, the ICAROS and AOs, they have to be degraded. So the proteasome is a need here, and if we combine a proteasome inhibitor with an IMiD, then there's also the potential that the two drugs may interact and inhibiting the IMiD function due to this interaction here. But we also know that IMiDs have other mechanisms of action, immunomodulating activities and anti-angiogenic activities. So there are other potential targets that benefit from the combination, which are why the IMiDs are now being combined with proteasome inhibitors, with cyclophosphamide, and also with monoclonal antibodies. So in addition to proteasome inhibitors to be the backbone of induction, IMiDs have become the newer backbones of treatment, either for induction or for relapse. And the studies which are using lenalidomide or the IMiDs as a backbone, their inclusion criteria and the number of lines of therapy is compared here. I took 4 studies, Aspire, Eloquent, Tourmaline, and Pollux. I'm sure that most of you have participated in these worldwide great phase 3 trials, and they were all successful, showing the benefit of the experimental arm versus the control arm. And here are the treatment durations and the median prior lines of therapy, which shows that Aspire and Eloquent are more advanced trials, whereas Tourmaline and Pollux are more earlier. You can accept them as first relapse trials. And looking at the drugs which are used prior to the introduction to the studies, there were very few patients who were refractory to Bortemomib, and certainly since the lenalidomide was the control arm, none of these patients are, except for the Pollux trial, only a few who are refractory to lenalidomide. So these are the characteristics of these studies. And stem cell transplant is also very common. And high-risk cytogenetics is something not to be forgotten. Again, is changing between 15% to 30%. So 15% of difference is a major difference. And regarding the response rates, the hazard ratio is the biggest for Pollux trial. And if you remember the proteasome inhibitor-based studies, the hazard ratios were mostly less than this. And the treatment durations are also very long, because most of these trials have been designed to give lenalidomide until progression. And here are the safety issues, and we can again see the comparison that these drugs are very safe and they are highly tolerable treatments. And when comparing studies across the board, one must also look at the control arm, how the control arms are behaving. That could be a tool to compare the studies. And the ASPIRE, ELOQUENT, TOURMALIN, and POLLUX studies, their control arm, their median PFS were roughly the same. But of note that the earlier studies which led to the approval of lenalidomide, these are better. So there's also the discussion that newer trials are including recruiting more patients at the biochemical relapse stage, and so that's why we are improving the results in both the treatment and also the control arms. And this is a comparison of almost all important phase 3 studies which are published so far. ASPIRE, ENDEAVOR, ELOQUENT, TOURMALIN, POLLUX, CASTOR, PANORAMA, and this study which is now going to be presented at ASCO and at EHA. They are all including patients mainly refractory to one or exposed to one class of agents. And it's not possible to see here in these studies double refractory patients. So, but nowadays, newer trials are aiming to recruit patients who are lenalidomide refractory, which is a population increasing with the introduction of lenalidomide for first line, mainly in the transplant ineligible patient population. So there are a couple of algorithms which are published. These are, although this one is dated 2015, it's already old because it doesn't include the monoclonal antibodies, but it's a very extensive and very good algorithm. And there's another one which was presented by the author himself yesterday by Saad Usmani, and it's also a very extensive overview of describing the approach for patients who, based on their previous exposure to IMiDs or PIs or autologous transplant. Here, there's a cutoff mentioned here, and also there are multiple combinations of IMiDs plus proteasome inhibitors. And I wanted to add to this, maybe after a few months, we will be able to introduce PVD into this algorithm as well. And finally, I want to introduce my own proposal of algorithm, which is I should say it's not so detailed, but based on it's maybe in future we will have more precision medicine and approach the patients in the more appropriate way that they deserve, not approaching all patients as a one apple in a bucket of apples. But this may give us the potential to add them an agent which they have been sensitive, again, based on the toxicity, or controversially, omit the earlier, the same class of agent and move to a more efficacy promising agents. And after they relapse, and here maybe Sagar would like to see that I have moved monoclonal antibody here in this setting to an earlier place, but certainly the monoclonal antibodies will have a place, maybe not in the very early relapse, but later in the relapse based on the biology of the disease and the previous responses that have been achieved. And finally, we have to note that myeloma is a disease which occurs in the milieu of genomic instability, and looking at the translocations, and there is a high number of mutations which are arising, and these are targets that need to be addressed. And Bart has also mentioned about the role of such as venetoclax or MEK2 inhibitors, and these agents may be added on top of the PI and IMiD-based regimens. And finally, I would like to conclude with a picture of our institution, and this time Philip Mora had visited, and afterwards Lolo also visited, but I don't have the picture here with me. Thank you so much for the invitation again.